from from chronic bronchitis. Okay, so COPD is chronic bronchitis and emphysema, but emphysema has the reduced DLCO. So they'll tell you that the patient came in with a young non-smoker with a spirometry of less than 0.7 and the FEV FVC. What is that, William? I was saying that in COPD, you have chronic bronchitis and emphysema. In emphysema, you have a reduced DLCO. In chronic bronchitis, your DLCO remains normal, and in some cases, it might be elevated. So emphysema is one of the few causes of a reduced DLCO, right? So they'll tell you the patient was a young male non-smoker whose spirometry showed this obstructive lung disease picture because the spirometry was less than 0.7 FEV FEC. They have a reduced DLCO. And what else are they going to tell you about the patient? They have deranged liver function enzymes. So he's a 23-year-old male, never smoked a day in his life, but he has some wheeze, difficulty breathing. You do the spirometry, it shows an obstructive picture. You do the DLCO, it's reduced, it shows an emphysema picture. You do a liver function test, his liver function enzymes are deranged. So what this means is cirrhosis plus pulmonary symptoms is one thing. That's alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. So to diagnose this, you have to test for alpha-1 antitrypsin levels. All right? And that's what they ask you. To treat it, you have to give alpha-1 antitrypsin. There actually is exogenous synthetic forms of alpha-1 antitrypsin. So that is everything you need to know about alpha-1 antitrypsin. Just to recognize it, it's emphysema plus cirrhosis. That's what it is, okay? But that's how the entire picture looks. Young, non-smoker with chronic obstructive disease. Usually expect emphysema and COPD to be in smokers, elderly, right, who smoke in a long time. But this is a young non-smoker. His spirometry is less than 0.7. It's irreversible, right? I see in Julian saying, and it's ER. I don't know what that means. What does that mean? Yeah, right? And so it is autosomal. What's the word, boy? There's a way they say it. They don't say autosomal recessive. They say autosomal codominant, right? Which is the same thing as autosomal recessive. Okay, so let's look out for that. Not autosomal dominant, it's autosomal codominant, which is autosomal recessive. Good. So that's alpha-1 antitrypsin. Good. So recognize it. Don't forget it. Emphysema, liver disease, alpha-1 antitrypsin deficiency, test the levels, and replace it as treatment. And the last thing would be our Wilson's disease. And then we're going to finish. Wilson's disease. So we know about Wilson's. The other name for Wilson's, you have to know, is hepatolenticular degeneration. So this actually gives you what happens in Wilson's. So there's due to copper deficiency. Copper deficiency, copper excess. Right, guys, this is when I get entitled here. Right, so there's due to copper excess, right? Because they can't really break down your copper or whatever as you should, right? So the pathway is liver, lenticular is the brain. The lenticulostriate arteries which run through the basal ganglia. So it's patholenticular degeneration. So it affects the liver, it affects the brain because you have copper being deposited in these places. You have elevated copper levels. So how does Wilson's disease present? It presents with brain symptoms. So it presents with CNS signs, and then it presents with liver symptoms. So the range LFTs. All right. So how I remember Wilson's disease is I had a very fantastic teacher who taught me the ABCD method of Wilson's disease and how it presents. So A for asterexis. Asterexis because of their hepatic encephalopathy. A for ataxia. Ataxia is loss of balance because of their basal ganglia involvement. B is actually for the basal ganglia involvement. And that's how I remember the name of Wilson's is hepatolenticular degeneration. C is a few things. C is cirrhosis. C is ceruloplasmin, and the ceruloplasmin levels are low. C is copper. Your copper is high. And C is these patients have a risk of carcinoma, that is hepatocellular carcinoma. Okay, increased risk of carcinoma. So that's Wilson's there. D is for dementia, because they also have cognitive defects and mood changes like depression. And E is for eccentric behavior. So these are the things that you will see in Wilson's disease. Asterexis, ataxia, basal ganglia, A, B, C, D, E. Learn that. Those are your findings. And then when you do a slit lamp, you're going to see Kaiser Fleischer rings. Oh, this brings something. So Kaiser Fleischer rings, right? So take a picture of that. That's everything you need to know about Wilson's disease. And the last thing will be the treatment. So to treat Wilson's, you have to do copper chelation, and we know the copper chelating agent is penicillamine. It will bind all the excess copper. So you have to treat them by giving them penicillamine and then reducing our copper intake. So we reducing intake of foods like nuts and chocolate, things that are high in copper, right? So reduce your copper intake because Wilson's is due to a copper excess. So you want to intake less copper and then get rid of it by a copper binder, which is penicillamine. All right. So last point, and then we're gonna answer the questions. It's 9:15, and I'm feeling sick as shit. So last point is this. So you have this patient. Okay. You have this patient. This patient has this. And this patient has this. All right. What's the first one on top here? What's this one? That's the eyes, right? What's this first one? Wilson's, right? So this is a Kaiser Fleischer ring. What is this one? Why am I telling you this? No, not cerebroblast. I'm telling you this because in one exam they brought a picture of an eye and asked the diagnosis. And it was between Wilson's and yes, correct. Correct. This is iris hamartomas. This is leash nodules. This is seen in fantastic neurofibromatosis type 1. So know that Wilson's, the Kaiser-Fleischer ring, is a ring around the cornea, and leash nodules could be mistaken for it, but it's actually iris hamartomas. So it's on the iris itself. It looks very similar, but in that case, it was an iris hamartoma. So leash has this consistent roundness. Sorry, Kaiser-Fleischer has this ring-like consistency, and your neurofibromatosis type 1 leash nodules have this in it. Okay, so the question, they brought an eye, and the options were, what's the diagnosis? That's the eye, that's the picture of the eye. Was it Wilson's or was it NF type 1? And it was NF type 1 because it was leash nodules. Okay, it wasn't Kaiser-Fleischer. So, good. That is that. So that's it. Any questions on any of those things we did there, guys? We clear on everything? Everything should be in your guide.
Hi, Doc. I have a question.
Sure, who's this?
Owen's here. Owen's here.
Hi, Owens. Yeah, what's up? Elma.
Okay, so just to recap, for in terms of hepatitis B, for chronic current infection, a hepatitis surface antibody is also positive, or it's negative. So for chronic current infection, the surface antibody is positive or negative?
For a chronic current infection?
Yeah.
Yes, positive.
Okay.
Sorry,
Okay.
you were sounding a little bit muffled there. Yeah. So let me
Oh,
just yeah, yeah, sorry. Hepatitis B specific antigen, hepatitis B um core antigen, E antigen, hepatitis B is it core antigen, hepatitis B um core antibody, hepatitis B surface antibody. So for a chronic infection, so once they're infected, we could work it out. Once they're infected, we know that it'll have positive here, positive here, positive here. Because the antigens are only positive if they're infected. If it's chronic, then we say that the immune system had enough time to make the IgG antibodies. And if it's chronic, it had enough time to respond to the surface antigen and make the surface antibodies positive. So this, yeah, this is it, right? This is it. Chronic diff current infection, right? Chronic current infection. So you can work it out once you understand what it is. Because I don't have, I actually just work it out. Right? So good. Sure, you're welcome. Good guys. So now we're gonna finish class here. You all got most things correct. So I'm just going to answer the questions, right? So 15, 23-year-old student suffered a needle stick injury. She goes to the clinic to screen for Hep B infection. Okay, so to screen for Hep B infection. So what I want you all to know again about the titers, Hep B surface antigen is the first thing, the surface antigen, right? Hep B surface antigen, right? Is the first to become positive, and therefore is used for screening. So if you want to test for hepatitis to screen, the hepatitis B surface antigen is you want to use. Next thing I want you all to know as I forget to tell you, is the hepatitis B E antigen is actually the sign of infectivity or contagiousness. So if these levels are high, the chance of transmission is high. So E antigen is correlated to how infective the patient is. So the higher the E antigen levels, the more contagious they are. So that's particularly high yield as well. Good. So that's number 15. Number 16, not going to read out the whole thing. Actually, we should, just to see how it presents. It's a young man, 6-month history of vomiting and lethargy. Been missing school and spends most of his time alone. So that's behavioral changes with some belly pain and some lethargy. His friends saw some vomiting because of probably like the little belly pain and liver disease going on. His friends concerned that he depressed, but now he has this brown green ring at the periphery of the iris in both eyes and signs of chronic liver disease. This is Wilson's disease. No need to think too hard about it. Number 17. So this is a 55-year-old woman with obesity, type 2 diabetes mellitus. She's seen in clinic for abnormal liver function tests. So this is literally how it presents in real life, right? Obesity, type 2 DM, and now her LFTs and weight. She don't have no jaundice, she don't have no itching. She never had weight loss, she has no appetite changes, and she doesn't drink alcohol. Her only medication is metformin for her diabetes, and she has a smooth hepatomegaly with a mildly enlarged liver. The rest of her exam was normal, but her ALT and AST was mildly elevated. Her bilies were normal. So this is a picture of diabetes, obesity with abnormal liver function test. She has AST and ALT mildly elevated as well, but the bilies were normal. This is a condition of MASLD or non-alcoholic fatty liver disease. Okay, no alcohol rules out alcoholic disease. Gilbert syndrome, because I think someone said that. What Gilbert syndrome is, just so you all know how it presents, Gilbert syndrome is where you have a deficiency of the um, glucurodynyl transferase enzyme, right? So that is responsible for breaking down or conjugating bilirubin, right? So this is responsible for conjugating bilirubin. So in Gilbert syndrome, you have reduced levels of that enzyme. And because of those reduced levels, you have a transient jaundice under stress. This is how Gilbert syndrome presents. Transient jaundice under stress. All right. So these patients with Gilbert syndrome, oh, it was usually, and that's fine, right? So know how Gilbert syndrome. So what they will tell you is the patient went to exercise or the patient was very sick, they became jaundice and it resolved. And every time that they exercise or every time that the body's under stress, they become jaundice and it resolves. So it's a transient jaundice. That is Gilbert syndrome. That is particularly high yield. Please write it down. Can anyone tell me what goes along with Gilbert? If it's not a deficiency of the glucurodenal transferase, it could be no enzyme at all. And what do you call it when you have no glucuronidase transferase? Excellent, excellent, Christina. That's Crigler-Najjar syndrome. I don't know how to spell it either, but it's Crigler-Najjar syndrome, right? So that's when you have no glucurodenal transferase. This leads to Kern-Icterus. This is not really compatible with life. This is pediatrics. The patient will usually die in infancy. Good. We'll talk about that when we do hepatic pancreatic or biliary for surgery. Nice. Um, good. So a 95-year-old, guys, I'm tired. A 65-year-old man presents to your clinic with a 3-month history of weight loss and a microcytic anemia. Abdominal examination is unremarkable. PR exam is unremarkable, but he has some fatigue. Guys, a 65-year-old man, microcytic anemia. Of course, we have to do a full anemia screen. We have to look for blood film. We have to look at ferritin levels, TIBC, which we'll talk about in hematology, the types of microcytic anemias. But guys, elderly man with iron deficiency anemia of no real source, we have to scoop him. This is GI malignancy until proven otherwise. Most of the times it is a right-sided colon cancer. So the patient may also complain about some melena stools. So melena stools, chronic melena stools with an iron deficiency anemia in an elderly male is not likely really to be acute upper GI bleed. It's more likely to be uh, right-sided colon cancer, right? But look at your entire history. It could be an upper GI bleed if it's melena and iron deficiency anemia. But if it's acute, then it's more likely an upper GI bleed. If it's chronic like this, 3 months with weight loss and so on, this is colon cancer until proven otherwise. Okay, but we'll also do an upper GI scope to make sure nothing else is going on. Long stem, basically, this is hepatocellular carcinoma, and the antibody for hepatocellular carcinoma is AFP. So please write that down, liver cancer antibody, alpha fetoprotein. This is a 30-year-old man, malaise, fever, jaundice. Exam, he had some needle tracks, so now he has hepatitis B, of course. His Hep B infection, he was lost to follow-up, and now he has hematemesis with ascites. Serologic tests were similar. So he has hepatitis B with now varices and ascites. He sees a physician again because he has weight loss and belly pain and rapid enlargement of the abdomen with an increased liver span. This is hepatocellular carcinoma secondary to hepatitis B infection. Very easy question, but it's just to correlate serum AFP as being the tumor marker for hepatocellular carcinoma. Great. And as you all said, this is autosomal codominant, which is autosomal recessive. Now, what I wanted to point out here for number 20, right? What I wanted to point out here is ooh, getting tired. Before y'all go, oh right, good. What I wanted to point out was the signs of decompensated cirrhosis or decompensated liver failure, right? Because I think I told you all, I started to tell you all it's the last class. So one is bleeding esophageal varices. We didn't speak about cirrhosis. It's in the guide, guys. We know a little bit about cirrhosis, right? Self-explanatory. Bleeding esophageal varices. The other one is ascites, right? Decompensated. So ascites plus or minus spontaneous bacterial peritonitis. The other one is encephalopathy, right? So hepatic encephalopathy. I always forget the last two because it's real easy. Jaundice is a sign of decompensated liver failure. And the last one, as forget, is hepatorenal syndrome. Right? You can read a little bit about hepatorenal syndrome. Kind of beyond your pay grade, kind of be on your pay grade, but MBBS could test it. Hepatorenal syndrome. Okay, so these are the features of decompensated liver failure. Please note them: hepatic encephalopathy, bleeding esophageal varices, ascites, jaundice, and hepatorenal syndrome. So in a patient who has liver failure, they may be okay living the life, and then acutely, because of probably an alcohol binge or a medication toxicity, some kind of thing could now worsen, cause a sudden decompensation of their liver failure. Just like how you have decompensated heart failure, you have decompensated liver failure, but this is how it presents. All right. All right, guys. So that was a lot. That was a lot. I am exhausted and feeling drained and terribly ill. Are there any questions? I do have all the energy in the world to answer questions if you have it though. So don't be shy. You all are clear on everything? Could you remind us the components of an anemia screen? You're supposed to be telling me that, Brianna. So if you want to do an anemia screen, right? You're doing the blood works. What you want to do? You want to do a CBC. You want to get blood filled, right? You want to get ferritin, of course. You want to get B12 levels. You want to get a folate levels. But concerning a microcytic anemia, if it's a microcytic anemia, apart from the ferritin, you want to do iron studies. So you want to do iron levels. You want to do ferritin. You want to do TIBC and transferrin, which are going to be the same, whether they increased or decreased. And you also want to do um, transferrin saturation. We'll talk about all of this in here because a very common question is that of ion studies and how to interpret it. Is it IDA? Is it um, is it thalassemia, or is it anemia of chronic disease? Okay, so we'll talk about that in here. But yeah, for uh anybody who has low blood count, this is ideally what we should be doing at the least. All right, a blood film with ferritin, B12, folate. If it's microcytic, we're gonna further explore the iron studies, ferritin, TIBC, transferrin, and the levels of iron as well. Good. Nice. Other question. Um, Doc, can you reiterate the next best test in autoimmune hepatitis? Is it ALKM or asthma? So for autoimmune hepatitis, honestly, we do both. I can't tell you which one is more specific, but we do both. And what I said was that when we, because we had a patient in October also when I was in um the first time I did neuro on a different team, we had a patient with autoimmune hepatitis, but her asthma was negative, but her anti-LTM was positive. But we send off both. I can't really tell you for sure if one is better than the other. Both of them can be found in autoimmune hepatitis. So it'd be kind of unfair to ask you which is which. Yeah? Welcome. Thanks, Chelsea and Brianna, for the questions. Any other questions? You're welcome, Brianna. You're clear? Alright, cool. Alright, guys, thanks for bearing with me. Sorry I wasn't in no loud and in your ears and in your face. I'm feeling terribly sick. I hope I recover by Saturday. Now, Saturday, just mentally prepare. Just mentally prepare for Saturday. Um, I'm gonna do upper and lower GI. So just mentally prepare. Bear with me and mentally prepare. Okay? I'm doing upper GI and lower GI. Okay, so you probably, if you all can make me, probably start 5:30 on Saturday. Um, but I'm doing both. Yeah, I'm doing both. You'll have everything you need to know, and well, you all will just have to, I give you all everything. It's just to study it. So once you have everything and any questions, feel free to message. Okay, guys. So thanks a lot for tuning in. Thanks a lot for participating. I will see you all on Saturday, please God. All right, take care, guys.